for joining in. The chat should be open. If not, Abhishek, please open the chat for everyone. We are open for your comments and suggestions. I think we have around 6 or 7 cases today with one follow-up. So without further delay, we'll start off with our first case. Razi, if Razi is there. Okay, I can see Razi. I'll make him a panelist. Wait. Razi, just check your Zoom. I've just upgraded you to a panelist.
Hello, good evening, everyone.
Yeah, that's good. Good evening.
16-year-old child, female child, presented to OPD with history of bladder incontinence initially for 5 days. Later, she had bowel incontinence 5 days later after bladder incontinence. Later, 10 days later, she had reduced speech output and responding to questions was decreased. She was responding to question after 10 minutes of asking the question. And 2 weeks later, there was complete absence of speech, and she had sleep disturbances. 3 weeks later, child presented with behavioral changes and decreased recognition of parents, and she was not recognizing. And 4 weeks later, the child presented with seizures, which were left focal motor seizures involving upper limb and lower limb. Initially, she went to other hospital. She went to NIMS, where she was treated with IV methylprednisolone and tapering dose of oral steroids, and first dose of injection cyclophosphamide was given. And later, like child sensorium, speech gradually improved, and she regained complete bowel and bladder control over 2 weeks. Then she came with complaints of recurrence of seizures. Initially right-sided deviation of eyes and neck and right focal clonic movements involving upper limb and lower limb. And one more type of seizure was rapid eye blinking lasting for 3 to 5 seconds. Like multiple episodes of seizures were there post treatment. There was history in the past as well. Like in September 2021, she got admitted in view of subacute onset encephalopathy with left-sided focal seizure, and she had a right UMN hemiparesis and facial palsy as well with hyponatremia. During that time, she was diagnosed to have aquaporin 4 antibody positive NMOSD. One cycle of rituximab, 2 weeks apart, was given, and IV methyl pulse dose was given. And child was started on maintenance oral steroids, which were in tapering dose. And maintenance mycophenolate mofetil was there, which was stopped recently in past, in November 2023. This episode of bladder incontinence she had in April.
Okay.
Yeah.
So I have 2 sets of scans. I don't have, unfortunately, I don't have the scans on the initial presentation in, I think, 2021 and later on in 2023. So this is the most, second most recent scan I have is in October 2023. These are the flare non-contrast sequences, and you can appreciate there are predominant abnormalities, more chronic abnormalities in the left temporal lobe. Some volume loss is demonstrated out there with some ipsilateral prominence of the temporal horn. Other than that, temporal lobe abnormality out there, again, you can appreciate it on the lower panel. These were the main residual changes in October 2023. Spinal cord, the cervical cord appears slightly hyperintense, but I don't have axial sections to confirm if there is true myelopathy there or not. So in October 2023, this was the picture. Optic nerves do not appear edematous. In terms of signals, they are not hyperintense. And then there is a follow-up, I think a recurrence or a repeat attack. And this was the scan in May 2024, external scan. And you can see that there is significant other changes demonstrated. These are T2 axial sequences, confluent abnormalities involving the gray and white matter structures, predominantly in the parasagittal frontal lobes, extending up to the corpus callosum, posteriorly also up to the cingulate region on the parietal lobes. And also involving the medial lobes on both sides, more on the left. On the SAT sequence, you can appreciate the extent of involvement, multifocal involvement on the corpus callosum, more confluent abnormalities in the frontal lobes and the parasite regions. Post-contrast sequences, again, have limited images, but you can appreciate there is some fluffy multifocal areas of enhancement, predominantly in the periventricular, anterior periventricular white matter, going up to the deep frontal white matter on both sides. Some perivenular enhancement also seen, some linear enhancement was demonstrated. I think this was the interval scan of plain scan focusing on the orbits. I cannot appreciate any significant abnormalities of the orbits there in these orbital cuts. And this is the angio sequence of the same scan which we have seen with the fully blown out abnormalities in the periventricular regions, possibly suspecting infarct. They wanted to rule out a ischemic abnormality, and as you can see that the angio is normal. There is no thrombosis or vasculitis type pattern or narrowing of the intracranial arteries. Yeah, Razi.
Yeah. Yes, sir. At NIMS, they underwent like vasculitis panel was done, which was negative, and for immunodeficiency workup, flow cytometry was done, which was normal, and immunoglobulins were normal. And in view of behavioral changes and subacute onset of illness, they did autoimmune antibodies panel, which was also negative. The past, like in 2021, she had NMOSD, for which she was undergoing treatment with maintenance with mycophenolate mofetil, which was stopped in November 2023. But now she presented with a relapse with MOGAD, like serum and CSF MOG and NMO was sent at NIMS as well, and repeat was sent to Amrita Kochi, which was moderately positive MOG antibodies and strongly positive for NMO. So the very rare case presentation of simultaneous involvement of both MOGAD and NMO. Now with relapse of MOGAD, initially presented with NMOSD. And very few literature is available on
Yeah, Radhi,
this.
just before you go ahead, just for radiologist point of view, what is they mentioned HEK cells? What is this? Is in the report? Fixed transfected HEK cells by cell-based assay. Anything? I mean,
Those are the cell lines which they use. It's a
Okay.
cell-based assay.
okay.
So those are the cell lines they use it
Yeah.
to transfected cell lines, and on that they test it. Antibody testing.
Okay.
Yeah.
Yeah, Raji. Sorry. Go ahead.
So, like double positive case reports with aquaporin and MOGAD is very few case reports are presented, and after so much duration of treatment with for NMOSD, there is no case report with presentation of MOGAD later.
Okay, so I at least found these are all adult cases, as you can see in the
Pediatrics. Yes.
Yeah. So adult cases I have seen. These are the dual positive antibody related cases, around 10 to 12 cases. But pediatric, I could not find anything. So this case was to demonstrate possible dual positivity, and if there is any experience with similar conditions in the children, that would be helpful. I'll open the case.
Nihal, as Nihal said, if there is a strong positivity of NMO, and then you have the mild or moderate positivity, it will be still taken as NMO.
Okay.
So that is what when I had a discussion with the immunology lab specialist on the similar lines. So there are around 4% dual positivity, which is seen. But the principles of treatment will be still based on the this one. What do you call the whichever is the strongest positivity.
Strongest. Okay.
Yeah. Here it's NMO.
Can we see this as NMO relapse only, sir, not as MOGAD?
I think our principles of treatment has to be NMO, because the strong positive is still NMO, isn't it?
Yes, sir.
So it has to be treated as that.
Yes.
But this is, I think, the third or fourth attack, Dr. Lokesh. I think
Yeah,
relapse or the
yeah, yeah,
relapse. So,
yeah. So we should give a strong immunomodulation only whatever the response for it.
What is your conclusion in terms of further treatment?
Razi, what are you treating the patient on as of now?
Like child based on the weight gain, because the last follow-up was in November. The dose of mycophenolate mofetil, like it was stopped for past 6 months. So it was restarted again, and again child was started on immunomodulator therapy. And omnocortil high doses and IVMP methylprednisolone, followed by maintenance of low dose corticosteroids. And
There's a comment.
cyclophosphamide.
Yeah, sorry. There's a comment from Ahmed Syed. We should go ahead and treat with FDA approved NMOSD management on second or third line. On second and third line. Okay. Mock positivity could be a silent observer, may not be pathognomic. So I think, as Dr. Lokesh has mentioned, we take the strongly positive variant, the antibody, for consideration, and I think we're treating this cell as primarily NMO. Okay. If there are no further comments, thanks, Razi. We just wanted to demonstrate the case and the lab findings. To our next case, Apurva, if you're there.
Hello, sir.
Okay, Anas, go ahead.
Yeah. So the child is from Vijayawada. It's about a 12-year-old girl, born to third-degree consanguineous parents, with no perinatal issues, normal development till 6 years of age. Then child had gradual progressive loss of previously acquired motor milestones, walking difficulty, now walking with support. History of similar complaints in the past of a younger sibling. On examination, child had cerebellar in the form of oculomotor apraxia, staccato speech, hypotonia, gait ataxias, and positive cerebellar signs. We'll be sharing some videos. So this is her mother. So she's swaying to either sides when she's walking, but slightly better. She was not able to walk earlier. Now with some rehabilitation, she's able to walk with some. These are recent videos. Earlier, she was way much further. Home videos.
Okay. Razi, anything in the fingers? Is that normal or sorry? I was just. Sorry, Anas, in the I was just looking at the fingers. Are they normal? I mean, that flexing of the fingers.
Not sure, sir.
Okay. So this is the sibling. All right. Anas, same findings on the video.
Yes, sir.
Okay, so I think this is a more severely affected.
Yeah, he's slightly more severely affected, requiring, he is able to walk, but with both shoulder support, but he's gradually improving over time as well.
Okay. All right. So I have the imaging of the elder sibling, that is the female child. As you can see, the main findings are in the infratemporal region. That is, you can see that there is some degree of volume loss in the cerebellum. The fissures and folia are widened, and there is cerebellar atrophy. On the flare sequences, we don't have a coronal flare, which is typically used for seeing the flare hyperintensities, but there is some degree of, I could appreciate some degree of hyperintensities in the cerebellar cortex, more on the left side in comparison to the right side. So supratentorially, could not appreciate any malformations or focal lesions, and in terms of other signal changes, it appeared to be normal. So main findings are predominant changes of cerebellar atrophy with possibly mild flare hyperintense cerebellar cortex out there. On the side and the coronal sequences, you can appreciate the distinction of the supratemporal and infratemporal brain. There is some volume loss, possibly from the hypoplasia out there. Even the brainstem structures demonstrate some degree of hypoplasia, and corpus callosum is mildly in the region of the body. No signal abnormalities on the GRE sequences in terms of blooming abnormalities or mineralization or hemorrhage, especially in the deep brain nuclei and the cerebellum, the brainstem structures. Yeah, Anas.
Yep. Tested, I mean, they're suspected to have an autosomal recessive form of progressive cerebellar ataxia because of the sibling involvement. We got a gene, APTX gene, which is pathogenic, and symptoms are matching. So it's basically a DNA repair disorder path in the same pathway. And such kids are also known to have choriotheroid movements. So possibly the movement that we are seeing in the video could be choriotheroid. But we have not examined the children from Srikanth's OPD.
Okay, so cerebellar atrophy in general was a non-specific finding in terms of the neuroimaging handles. So this was a gene which came out to be positive. We had two other cases, I think, which were previously discussed in this forum. This was a child, a 7-year-old male child, again had cerebellar abnormalities, also had oculomotor apraxia. And you can appreciate that the isolated involvement of the cerebellum with some flare hyperintense cerebellar cortex out there. This child also had the gene for the APTX mutation. And this was another case. I think Dr. Prerna is there on the panel. This child was an 8-year-old with, again, cerebellar issues. Her maternal aunt had similar presentation, imaging clinical phenotype. And this child was again scanned over a period of 2 years. And you can appreciate that there is, again, cerebellar volume loss. Relatively stable, slightly improving, but yeah, as you can see, that predominant cerebellar abnormality with the typical clinical findings. And this was again a gene for APTX mutation. As Anas has pointed out, I think this is from the OMIM, and the main findings, as you can see, are the oculomotor apraxia, the cerebellar gait abnormalities. Also, Anas, any idea if the child had hypoalbuminemia or hypercholesterolemia, which is seen in more than 3/4 of the people?
Yeah, albumin was low. I'm not sure about the cholesterol levels, but I have albumin well low.
Okay. So yeah, these are, I think, 3 cases with similar clinical and imaging phenotypes. So if anyone has any similar cases of the same gene, the treatment and their prognosis, that would be helpful.
Can I ask, before you got the result of the genetic test, which of course now is explaining everything, did you do some clinical reasoning? Have you suspected something? Why did you measure or not measure alpha-fetoprotein? Because, I mean, ROR1 and 2 are top on your differential diagnosis. The child was 6 years old in good condition, which is completely against Lewy Body syndrome AT. This is my question. Did you do some thinking in advance or just rely on genetics?
So the point of initial contact, possibility of ataxia telangiectasia was considered initially. I mean, autosomal recessive cerebellar syndrome was considered. Alpha-fetoprotein was sent as well. That came to be negative, as the child did not have, and the sibling was evaluated prior. Clinical exome was sent to the younger sibling elsewhere. It was already negative, so they didn't have an answer on clinical exome. And as the alpha protein was negative and it was not matching a phenotype of ataxia telangiectasia completely, it was sent, but further clinical details are not available because it's a case from Vijayawada, so we have not. It's Dr. Srikanth sir is following it. But yes, alpha protein was sent, and it was put in the group of autosomal recessive cerebellar ataxia syndrome, because child had oculomotor apraxia as well. I think that was.
I understood. I understand. If you have a child with progressive ataxia and ocular apraxia, and this ocular apraxia is true, then your differential diagnosis is, your list is very short.
Yes.
And if you would not be able to afford genetic testing because of financial constraint, my next point would be still to measure alpha theta protein, to rather point towards AOA1 and against AOA2, because in the latter, alpha protein is often markedly elevated. I hope I was not too confusing.
This is Dr. Prerna. I think I would agree with Dr. Balthos. The companion case that I had, the girl who had this APTX mutation, her AFP initially was just borderline on the lower side, but later her symptoms became, there was progressive worsening of her symptoms despite treatment, and there was a slow rise in the AFP. Currently, she's non-ambulant, and she's almost mimicking, what her aunt had, and who became non-ambulant and bedridden by the time she was a teenager. So I think you need to monitor the AFP levels in case there is clinical worsening, or maybe in 6 months to 1 year. I mean, 6 monthly, probably.
That's important actually, because we have done it only once. We have not followed up the AFP levels.
Yeah.
But that's an important learning point.
Right. Thanks again. Thanks, Dr. Vena. Thanks, Anas, for taking up the case. Yeah, few good learning points out there. Okay, if there are no further comments, then we'll move on to our next case. Anas, over to you.
This is about a 5-year-old boy born to third-degree consanguineous parents. He was apparently asymptomatic till 3 years of age. Other than he had some recurrent infection for which he was getting treated elsewhere. His development was on par with peers in motor domain, and cognitive-wise he is fine, but he had some speech delay. He only attained bisyllable by 1 year. So at 3 years of age, in view of prolonged fever for almost 2 weeks and recurrent vomiting and 1 episode of seizure, he was admitted at a government hospital where he had developed encephalopathy, and a neuroimaging was done, which was suggestive of cerebralitis. And then later he had signs of raised ICP, for which a VP shunt was placed, and a CSF analysis at the time was normal. So he was discharged after a 1-month stay. So later, post discharge, he had a motor regression because of the cerebral signs. He had severe ataxia, which improved over the time of over the course of next 2 years. So when he so at 5 years of age, that is this current, he was able to stand with support, was ambulating with bottom shuffling. His speech had improved 15 words, was indicating for his toilet needs. He was not going to school, but was being taught at home by the mother. He had learned some few alphabets. But he was more or less dependent for activities of daily living. So this was the initial thing. Yeah. This is just prior to the morbid illness at 5 years of age. This is just clinical image. He has hypopigmented.
Yeah, okay.
Yeah, he has hypopigmented hair as well as eyebrows. And they were told that even the elder sibling also had similar hair. And she had she was also development normal till 3 years of age, after which she developed high fever and low blood counts. They don't have those reports, but they were told that she had organomegaly, and she was diagnosed to have some sort of blood cancer. That was told to them, but and then child succumbed to encephalopathy and seizures. So this child,
are these the differentials by any chance? Common differentials? At least this is what I found.
Yes. So in view of the silvery hair appearance with the recurrent infections and history of similar presentation in the elder sib, possibility of in the silvery hair syndrome, Griscelli and Shirakashi are ones. And both of them have the predisposition for developing HLH.
And
So,
this is in,
so this was the morbid event at on March 2024, that is 3 months earlier. A child presented with status epilepticus with fever, for which he was intubated for 6 days. There again, he had developed signs of raised ICP. They treated in the lines of meningitis and CSF culture was negative. Cells were showing 15 cells, all lymphocytes. Protein sugars were normal. So the child was treated like meningitis for 21 days with IV antibiotics and discharged. So post discharge,
I think I have the images for March. Yeah. Okay. So March we have images. T2 axles out here, and you can appreciate there are some periventricular abnormalities, predominantly in the posterior hemisphere. Also coming more superiorly, the frontal lobes also demonstrate periventricular and deep white matter changes. So the confluent abnormalities, some are focal abnormalities out there. Some degree of volume loss in the cortical regions of the cerebral hemispheres on both sides. Let's see, it's possibly some changes in the left basal ganglia, but yeah, predominant white matter changes. But the main changes are in the posterior fossa. I think previously, as Anas has mentioned, that there was a possible diagnosis of cerebrolitis. As you can see, there is chronic changes in the cerebellum. There appears to be a focal lesion out here, centrally cystic appearing lesion with some areas of T2 hypointensity. We don't have the gradient images to correlate if that is hemosiderin or not. But yeah, so this focal lesion is causing some mass effect on the brainstem structures and the worm is out there. Yeah, so these are the main abnormalities on the March scan. Post contrast, you can see that there is extensive linear focal nodular enhancement in the posterior fossa structures. Leptomeningeal enhancement also demonstrated along the inferior cerebral hemispheres on both sides. Diffuse leptomeningeal enhancement in the supratentorial brain. Again, better appreciated. You can see on the coronal sequences, the posterior fossa abnormalities are extensive, and on post contrast, the changes are what we see are typical for what we think of HLH type pattern. There is some degree of hydrocephalus also because of the cerebellar abnormality. Following that, yeah.
Currently, as well, child is not with us. This is parents had come to us with the document. So again, so he after discharge he was bedbound, but he was showing some signs of improvement and of sensorium. But again, 2 months later, he presented with a similar presentation: fever, prolonged fever, vomiting. Again, status epilepticus requiring mechanical ventilation again for 6 days. Currently, he is on NIV. He is stuporous, arousable to only deep pain, but is not recognizing family members. So now the referral doctor they were wondering because they have done LP and this time proteins were high along with cellularity. I think it's in the next slide. CSF.
Oops. Sorry, I think I missed that. Yeah.
Okay, yeah. So CSF showed high protein north of 200 with and some cellularity. 45 cells or lymphocytes. So they're wondering if and they had done CB-NAT of the same sample and PCR, which are all negative. So they're treating in lines of meningitis again, considering and immunodeficiency workup so far is negative. And they have done whole exome as clinical exome as well. Problem is now the doubt from the referral team is it just CNS HLH or is it some infection? And so they had come to us for review.
This is a follow-up scan in June. Yeah, again June.
Yeah,
You can see that the white matter changes are reduced, but there is more gray matter involvement. More cortical abnormalities diffusely on both sides. Basal ganglia thalamus also abnormal on the present scan. The cerebellum demonstrates these chronic changes, which we have seen also in the previous study. Not able to appreciate the focal lesion. At least it has reduced in size in comparison to the scan in March. Contrast sequences again supratentorially again demonstrates this diffuse enhancement pattern. Posterior fossa, there is reduction in the contrast enhancement pattern in the posterior fossa structures, as you can see compared to the previous image. The enhancement and inflammation is reduced in the posterior fossa and the cerebellum. At least there are some punctate abnormalities in the brainstem. Yeah, these are the findings on the latest scan in June. Following this, I think whole exome was done. Yeah.
Yeah. So other labs, they have done PID panel as well. Immunoglobulin levels were normal. Subset wise, CD4 45%, CD8 21%, NKSL percent 9%, CD4 by 8 to 2:1. That PID panel was essentially negative. And this whole exome was done priorly actually because in view of they had done it, yeah, ferritin. Let me see. Yeah. Yeah, ferritin is 500 and fibrinogen levels were low.
Okay, so at least imaging wise, we agree that it fits into the HLH pattern. This is just a clinical slide I found on Google, and yeah. So the question here, Anas, if you want to just
Yeah, so we were thinking it to be HLH, and principle of HLH has to be the child has to be treated in the same line, but they had a doubt, is it TB or something else like a granulomatous lesion or something like that. That was their main concern. Because ferritin was not very high, although fibrinogen levels were low. They have not done so its bone marrow was not done. So they were still wondering if it's just an infection associated with the Gracilli, or is it just an HLH?
but infection will not cause the clinical picture. I mean,
Yeah, yes, that's what our opinion was, but that's I just wanted to.
all right, I'll open the case for further discussion.
And nothing PCR and other infections did not show anything. Either.
CSF cytospin?
No, not done.
Not done. At least imaging wise, I mean, we favor more of HLH type pattern. Okay, bone marrow is the question asked.
As far as the documents and what we have done, the bone marrow is not done.
But normal infection will not have at least this clinical picture, no?
So I think what question that treating physicians they have it, the child did not require HLH treatment last time and the previous time as well, and despite that child did show improvement. I think that was the main question they had. So I think, but this time is more much more severe, and it's still quite encephalopathic.
I mean, there is progression supratentorally, infratentorally, no, but yeah, white matter is reduced, but gray matter structures are no showing the lesions. So again, this is not. Yeah.
Yeah. Other question is it just explaining everything can be explained with one pathology? That's another. Or are we looking at some dual?
But you didn't get anything on CSF and CVNAT, is it right? PCR?
Nothing, sir. Nothing.
Okay. Yeah, if anyone has some comments, I think we're dealing with HLH, but yeah, and related infections. There's a comment that the infection would have rapidly progressed and child would have succumbed. Therefore, it is primary CNS HLH from Uddhava. Thank you.
That's everything. Just but wanted to review in the meet as well.
And the gene is significant, right? I mean, though it is uncertain.
Yeah, it's a gene is significant, and reverse phenotyping has been done. There's the done microscopy of the hair as well, which is suggestive of Gracilli, the clumps. The pattern is characteristic. So diagnosis, the gene in question is not in doubt, but only I think the underlying etiology. Is it just a infection versus demyelination or both?
I think we will favor HH-related CNS imaging findings rather than only infection, and to be treated accordingly.
Yeah. No, they have not given steroids yet, but we've asked them to. I think we have to yet to get update how the child responded to steroids. But I think when they came to us 2 days back, so we have advocated for steroids already, and I'll just follow with them. How's the child doing now?
Okay. Yeah, I think let's see. All right. I think there are no further comments. So primarily we're thinking of HLS-related CNS changes, Anas, and yeah, you can give us a follow-up if the child is improving on medications.
Thank you.
Okay, thank you. Next case also, Anas.
Yeah. So this is a 4-month-old girl from West Bengal. Child was fine until 1 month. Then parent noticed gradual weakness of lower limbs at 1 month of age. There was no history of trauma, fever, and for the paucity of lower limb, she was evaluated elsewhere in Kolkata, where they had done neuroimaging, which was suggestive of a lesion in the mid thoracic level. So for that, she was evaluated as and diagnosed to be CNS toxoplasmosis, for which steroids were started, sulfadiazine, pyrimethamine, folinic acid was started. So with this medication, there was some gradual improvement in the lower limb function over time. So when they had presented to us on examination, she had poor fixation, macular scar on fundi examination. There's some asymmetry in the eye, left eye being slightly smaller, and features of sunsetting were present. AF was tense, head circumference 41 centimeters. The serial head circumference showed gradual increase in head size. And lower limb hypotonia with weak power, only 1/5 with ankle and patellar conus.
Okay, so just a question, the first scan was only a spine done or a brain also done first?
Yeah, the brain was done as
Okay.
well.
Okay. So I have the recent images which was done at our center, and you can appreciate that there is significant ventriculomegaly or hydrocephalus. There are some T1 hyperintense areas, predominantly in these particle regions. This will demonstrate blooming on the SW sequences related to some degree of mineralization out there. Also in the corticothalamic groove on both sides, there are some focal abnormalities. Macrophthalmia on the left side with some vitreous opacities and lens opacities on the T1 weighted sequences. And you can see that there is, as mentioned, significant hydrocephalus on both sides. These are the filtered SW sequences, and you can appreciate that there is some blooming of the abnormalities which are demonstrated on the T1 weighted sequences first of calcification. We don't have the initial spine images where the lesion was demonstrated to be known at around D9, D12 level. So on the follow-up scan, you can appreciate that there is a focal reduction in the volume, but there's no lesion, present lesion, no lesion in the present scan, no enhancement on the present study. On the SAT sequences, you can appreciate that there is aqueductal narrowing resulting in the supratentorial findings of the ventricles. No other areas of abnormal enhancement were demonstrated, no meningitis. Yeah, these were the main findings, ventriculomegaly, calcifications, this focal chronic change of the lower dorsal spinal cord. Based on the, I think I already mentioned that the initial thought was torch infections, and given the imaging findings, thinking of toxoplasmosis. These are possible imaging findings which can be related to the time of insult. Not very specific, but yeah, these are just a rough estimate of the possible imaging findings with relation to the age of insult in the entire time period. Again, these are again differentials for classification, just few examples out there. And among these, if you see the only case which has, or the only condition which is commonly known to have ventriculomegaly or hydrocephalus is toxoplasmosis. This is a good paper, I think it was published a couple of years back, reviewing the intracranial classifications in 2 parts. And again, intracranial classifications with hydrocephalus, think of toxoplasmosis in the congenital infections. Spine lesion was mentioned. I don't have any experience of spinal cord congenital toxoplasmosis or postnatal toxoplasmosis, but I think I could find only few cases in literature. Even over here, you can appreciate that there is some intramedullary abnormality out there. They have mentioned some abnormality out here, but I could not appreciate it in these images. And again, over here in this scan, again, they have mentioned punctate abnormality, but yeah, over here possibly. Yeah, these are the review of literature which has spinal abnormalities with toxoplasmosis. So we just wanted to know if anyone has seen any prior cases with spinal cord lesions with toxoplasmosis or other torch infections. And this was the follow-up. Yeah, Anas, you can go ahead.
So at the referral center, they had done toxoplasma IgM, IgG, and IgM levels at 1 month of it. That is at presentation. IgM was 3 and IgG was 200. Later at 1 month when it was repeated, IgGs remained to be high 200, but there's a reduction in IgM level 0.06, 0.6. LP was done initially at the referral center, which showed high protein 2200. Protein and sugars were normal. BERA was normal. So we have done a ventricular tap of this child. Protein sugars are normal. No evidence of any ventriculitis. Child is planned for a CSF diversion procedure, either ETV versus VP shunt. Parents are yet to decide on the mode of surgery.
Okay, so the main question here is spinal cord experience with
The spinal cord,
toxoplasmosis.
yeah. So typical presentation is about it. Otherwise, as risk factors, retrospective history, there was history of some fever, non-specific fever at 5 months, which was self-limiting. Head size at birth, head circumference at birth was normal. So the classical risk factors or any things were not. HIV status of the mother is negative. I think baby HIV status, I have to review, ma'am.
Yeah,
Immunodeficiency
sorry,
has not been. Immunodeficiency workup or other HIV workup has not been done for this baby as of now. They just came to us a couple of days back for this second opinion.
I have no experience with spinal cord involvement, almost never seen toxoplasmosis in the last years. I think it's very rare observed in Central Europe. Is it more common in India, perhaps?
Anas?
Toxoplasmosis?
No.
Relatively less common as compared to CMV, but we do see cases. The spinal we have not seen from our center at least.
All right. So Dr. Lokesh also mentions that toxoplasmosis is not common. The other, I think, caveat is for toxoplasmosis torch infections, we usually only stop at screening the brain, whether we could pick up more lesions if the spine was done. Question is any role of TRT? I'm not sure what TRT stands for, but yeah. Anas, do you know any idea? TRT? Yes, could you put in the full form of TRT there? Okay, any role of treatment at present scenario? He has been advised for CSF diversion as of now, I guess, to relieve the hydrocephalus. Dr. Gauri mentions exposure to cats, and the mother is
Yes, they don't have a pet cat or any that they could have been but I think should we ask them to work up for immunodeficiency? Will that be reasonable, or because we don't have a strong risk factor as such?
Okay. Dr. Lokesh mentioned that neighbors had a cat, so possible route of infection there.
Thank you.
Okay, there's a comment of need for immune workup from Dr. Riaz Ahmed.
You mean
Okay.
workup in the mother or in the child or in both? I mean, this is a congenital infection. Transplacental.
Yes, they're mentioned as both. Okay, so yeah, toxoplasmosis in general, the less common torch infection, spinal cord lesion, very rarely seen as highlighted here. I think many of us don't have any experience of spinal cord abnormalities. Unfortunately, I don't have the initial scans, but what was mentioned was a focal intramedullary abnormality in the lower thoracic cord with peripheral enhancement, if I'm not mistaken. On the follow-up, yeah, it has reduced. I mean, it has resolved completely, but leaving some focal cord atrophy out there. Yeah. So I think of risk factors, as Dr. Lokesh has mentioned and Dr. Gauri has mentioned, and possible immune workup to be done. Anas, okay?
Yes, thanks.
Okay, thank you. All right, from Rainbow, we move to BVP Pune. Krishna Priya, if you're there.
Yes, sir. Good evening, all. This is a 4-year-old child who came to us for cochlear implant surgery fitness. Apparently, she has been deaf from birth. So she was a term child and cried immediately. She was AGA. She had a birth weight of 2.9 kilograms. Her mother did not have any fever during the antenatal period. And she had a normal motor development, but with speech delay because of the deafness. And she is being trained in sign language. She is born to a non-consanguineous parents. She has 2 siblings who are normal in development. There is negative family history of deafness, or there is no progressive neurological illness in the family. On examination, she is alert and she has a warm temperament. She communicates well in sign language. And gross motor wise, she is running well. She is going up and down stairs. She can copy a circle and a square, and she is going to the toilet alone. She has no cranial nerve deficits except for the bilateral profound hearing loss. Her head circumference is 47.2 centimeter, which is coming at the 50th centile. Her tone is normal. Dependent reflexes are 1 plus. She has no cerebellar or sensory symptoms or signs. There is no pallor or organomegaly.
Okay, so I have the most recent scans. Krishna Priya.
Yes, she got imaged for the cochlear implant. So they have done temporal images as well as the brain images. So this is what we found.
So yeah, we have flare axis sequences here, and we have multifocal abnormalities again in the deep and subcortical white matter in the bilateral hemispheres out there. Coming down inferiorly, you can appreciate some cystic abnormalities in the temporal lobes, more on the left side. Some refractory changes on the anterotemporal on the right side. Some periventricular cysts in the temporal horns out there. I think that will be better appreciated on the cyst sequences. No structural abnormalities on these flare scans. So temporal bone imaging was done. Could not appreciate any abnormalities of the inner and middle ears. The cranial nerves were normal. 7th and 8th nerve complexes were normal. You can appreciate the temporal lobe, temporal horn cystic lesions out here, the periventricular cysts. There is a ventricular adhesion in the left occipital horn out there. Again, some temporal horn cystic lesion. And on the SAT sequences, you can appreciate some degree of brainstem hypoplasia, some thinning of the posterior corpus callosum for a 4-year-old. CT scan was done, I think, to look for calcifications. We could not appreciate any calcifications on the CT scan. I think these are 1 millimeter cuts. So yeah, I think based on the imaging, in prime consideration with thinking was congenital CMV. The findings which are present on our index child are present here, which are commonly described. Posterior predominant white matter lesions, temporal lobe abnormalities in terms of refractory changes of particle cysts. White matter abnormalities can be variable. Ventricular separation adhesions also commonly seen in cytomegalovirus-related infections. The child has sensory hearing loss and has a circumference less than 5th centile. I think this was the prime consideration based for this child. Other differentials, if you just look at the cysts as an imaging pattern, CMV is the most common close differential is the interferon-related disorders, that is acardic uterus syndrome, but they can also be seen in other conditions as mentioned out here. I think out of these, if I'm not mistaken, RNase T2 and mitochondrial might have hearing issues. Yeah, some of the clinicians can correct me. Yeah, so thinking of CMV as the primary differential, possibility. Krishna Priya, the question was any specific question for the child?
No, sir. We were also thinking of CMV. only that there was no history of maternal fever and there was no significant microcephaly, no calcifications.
No, so I think actually when we had discussed this in the radiology with the radiologist, he told us those temporal cysts were enlarged VR spaces. So we were not very sure that how can something like that, I mean, have there's a bit of edema and things around those temporal cysts also.
Okay. VR spaces.
Yeah, so they told us these are VR spaces which we did not agree with. And basically these white matter lesions are more like FCDs. So
Wait, multiple FCD?
yeah, that's what. So we were not convinced, and
Okay.
so we brought it to this.
I mean, if you see, I mean, these are not, I think there are 4 millimeter cuts, but you can see the white matter lesions and the
Yeah.
cortex. You can appreciate the interface out there. Just maintain multiple STDs is almost as rare as spinal toxoplasmosis, unless the child has tuberculosis with particle tuber-like demonstrations. As I've mentioned out here, majority of the findings looks like a straightforward CMV on imaging. Yeah, I think everyone agrees on the chat to Dr. Vijay, Dava, Yogesh also mentioned as CMV. I think clinical also fits, if I'm not mistaken. So
if suppose this was a different child and we are thinking of AGS and the cyst associated with AGS, is there any way to differentiate?
yeah, the AGS, what commonly seen is the white matter abnormalities are more confluent, they're more frontal dominant. The calcifications are in the basal ganglia, more centrally calcified regions. These multifocal abnormalities are not commonly seen in AGS. The more common pattern is more confluent abnormalities. Bilateral hemisphere asymmetrical pattern, more frontal dominant. CMV, usually has some degree of cortical malformation that there's an earlier insult. Yeah, but white matter pattern also is slightly different for AGS.
Okay. Thank you.
And microcephaly, is that a common finding for AGS? I'm sorry.
No, it's not. It's
yeah,
not.
yeah,
but with CMV it is, yeah.
Okay.
Just a question, not a criticism. If ever possible, cochlear implants should be done already in the first year of life in congenital deafness, if this is an opportunity, but it may depend on the services available.
I think the parents did not pick up the speech delay till quite some time. And the workup took some time, so she became 4-year-old by that time.
They are from a remote place.
So yeah, I think we have cleared your dilemma. I mean, there was no dilemma on your end, but yeah, we are all agreeing that these are CMV related changes.
Thank you.
Thank you.
Thank you.
Yeah, this is our last case. I think it's a follow-up case previously discussed a couple of times in September and October 2023. Anas, if you're there, over to you. Oh,
Yes,
sorry, just a minute. Dr. Gauri has a question. Whether the cochlear implant will help the child, there are some radiological criteria which are lack of extensive white matter knowledge can predict fair outcomes. I'll have to check on that, Dr. Gauri, related to the white matter abnormalities and the results of the cochlear implant. If anyone else has any experience on that.
I'm not an expert, but of course, in addition to implant, you need extensive training by specialists. But this child will likely benefit from this intervention in terms of language and communication.
She seems cognitively okay, so we felt that she would probably benefit from the surgery.
Good point.
Yes, thank you. I think Dr. Gauri also agrees. So thank you, Dr. Prerna. And I can. Okay. So our last case, Anas, over to you.
She's now a 7-year-old girl. She presented us last year with history of headache, blurring of vision, double vision for 3 days, and 1 day history of photophobia. Prior to that, she was all developed normal. On examination, she had upgaze restriction and no other neurological deficit. Some RAPD was seen, left more than right. So an initial MRI was done. Do we have that, sir?
Yeah. So initial MRI, I think we discussed this last year itself. There are multifocal abnormalities predominantly affecting the white matter structures, bilateral hemispheres, periventricular deep, predominant, some ranging up, going up to the subcortical regions, supra and infratemporal abnormalities. We are thinking of demyelination out here. And flare sequence, again, you better appreciate the multifocal abnormalities. Post contrast, some of the lesions demonstrated complete enhancement, but majority of them had some degree of incomplete ring-like enhancement pattern. Optic neuritis were demonstrated on both sides, more along the proximal pathways. So yeah, based on this, I think we thought of demyelination. Spinal cord was normal. Yeah.
Yeah. So yeah, so at that point of time, she was worked up for a demyelination possibility. VEP prolonged both sides. CSF oligoclonal bands were negative. CSF viral panel was negative. Serum NMO MOG was sent to Amrita Kochi cell-based assay. That was negative as well. CSF showed 3 cells. Protein and sugars were normal. So she was treated with pulse dose methylprednisolone, and over the time, she improved within 5 days. At first follow-up, she was back to baseline. Her gaze restriction had improved. She was started on tapering dose of steroids because as it was a MOG negative demyelinating lesion. She was treating, we were treating her on the same basis. So on tapering dose of steroids, a couple of months later, she presented to us again. This was in October. Presentation was just 1 day history, fever, some double vision, photophobia, 1 day history of fever and vomiting. So repeat imaging was done. Do we have that, sir?
Yeah, repeat imaging, I think more or less similar findings, what we have seen in the initial sequence, initial scan. I don't have the scan images, but from the films, you can appreciate again multifocal abnormalities, predominantly white matter involvement, supra and infratemporal involvement. Yeah.
One more thing, I mean, I think a week before this second presentation, we had done a follow-up interval MRI, which had showed improvement in some of the lesions, not all. So yeah, I think that was one factor. But then, I think just 1 week later, she had this relapse.
Okay, all right. So then we have another follow-up in June. So anything from October to June?
Yeah. So yeah, at this point
In
of
terms
time.
of
Yeah, so this was the second presentation. Again, we had research steroids and we did GFAP and we had repeated the MOG. And so again, these were
clinically
negative.
anything?
No, again, she improved with steroids again. So over the past now, she's asymptomatic essentially.
Okay.
So we planned after discussing with our immunology colleague, we decided we'll put her on monthly IVIG. So she received 6 doses of IVIG and an interval scan was done after finishing the 6 doses, and repeat CSF, repeat serum MOG was done from Amrita again, which was negative. So this is
I think
current
oligoclonal
MRI.
band also was done, no? Yes?
Yeah, CSF oligoclonal band was done at the onset. That was negative.
Okay. All right. So follow-up scan in terms of the neuroimaging, there's, I think, interval reduction in the abnormalities. Again, some persistent abnormalities are there, but in comparison to the scan in October 2023, at least the neuroimaging findings have reduced. Infratemporally, there's complete resolution of the imaging findings, at least on these images. Possibly a focal lesion out there, but yeah, reduction is more in the infratemporal compartment. Supratemporally, there are residual lesions, but again, in comparison to the October scan, as you can see, multifocal abnormalities, the number of lesions have decreased. So yeah, so there is imaging, at least there is some improvement. Again, flare sequences better demonstrate the lesions out there. Optic nerve cuts do not demonstrate any optic neuritis, though this is a pain scan, no optic nerve edema change is demonstrated. And then at that time, these are just discussion slides which we had thought of at that time. Possibility of MOG, ADEM and MOG-related abnormalities. Also to think of multiple sclerosis was one of the considerations on the second, at least the second follow-up, and even as Anas mentioned that on the baseline evaluation, the oligoclonal bands were negative. So I think Anas, what is the other differential we thought was possibility of other neuroinflammatory disorders such as Behçet's, but I don't think the child had any skin lesions.
So only now she's asymptomatic, but the lesion is still there. Again, now current the differential is it just an MS, a pediatric MS? So
No, the
any
question
point in
is, yeah, no, just a second. Sorry. The question was, it's almost more than 6 months from the last acute event, and still so much of residual signal changes which are there, although they are not active. So, does it happen in some of these MOGs, which or most of the times we see by 3-4 months there is a significant resolution? That was the main question.
Dr. Gauri raises the possibility of multiple sclerosis, Dr. Lokesh. This comment, if serum NMO MOG is negative, should we go for CSF NMO and MOG? Another question. Uddhava shares similar case with findings progressing to eventually having MS. Was on IVIG for 6 months and then recurrence within 2 months after 6 months of IVIG. Spinal MRI was not done on the present study. Riaz, to answer your question. So Anas, the MS was tested only at the time post on September, right? Not recently, not again.
yes, sir. We've not done oligoclonal bands again. We did repeat the MOG NMO.
Okay.
And GFAP at the second presentation.
Dr. Gauri says oligoclonal bands not an invariable finding in MS. How was the VP at the current? I think VP is prolonged. Is this the latest?
No. Now it's normal.
Okay, so previously was raised, but now it's. Question here is: should we think of MS as because the child hasn't improved, and there were some lesions which had was linear type pattern with some open ring enhancement else. I think on the first scan, so yeah.
The partial ring, can it be seen in other demyelination as well? Like
Yeah, I mean I was seen in MOG the open ring. I mean and also in vasculitis type related lesions. We have seen neurobasets, but I think I have put in that case. As you can see over here, some of them had an open ring type pattern of enhancement. But they're the okay. There's another comment on the SAD sequences. I think yes. Let me see. Yeah, this linear oriented pattern sort of MS possibility. Yeah. So honestly, I think to summarize, I think majority are thinking to raise the possibility of pediatric multiple sclerosis as for this child. So Riaz mentioned optic nerve thinning. Optic nerve thinning could be manifestation of MS or chronic change for an inflammatory disorder. At least on these cuts, I cannot appreciate any optic nerve thinning. And VEP being normal also, I think. Is that right, Anas? If VEP is normal, think of MS. Sorry, I'm not.
Yeah, recent VEP is normal. Yeah.
Okay.
So
Okay.
do we need to do any further imaging at a scheduled interval? Because she's clinically asymptomatic now for this.
Imaging wise, I don't think so, Dr. Lokesh. I mean, I think this was done recently itself.
Yeah, recently. So follow-up imaging every sort of 6 months.
Do we test again for MS is the question.
Yeah, I think if there are any new lesions, then we do. Yeah.
Some of the patterns, I mean, some of the lesions look like MS, so I think maybe we can get a repeat test for MS.
Okay. Okay. Sure. Okay. We'll discuss. Thank you.
Thank you. Thank you for the comments.
Thank you. OCT, Anas, Dr. Riaz asked, was an OCT done?
Okay. We've not done now. She's doing well, so we have tested it again.
Okay.
Will it help now? Otherwise, her repeat VEP is normal. Clinically, this electrophysiology wise as well.
Okay, so yeah, I think we'd like to evaluate for for MS for now and maybe get a follow-up scan down the line, 6 months down the line.
Sure. Thank you.
Okay. Thank you. If there were no further suggestions or comments, that's the last case, and we'll again meet in 2 weeks' time.